up next, I'd like to invite Dr. Margaret Steele, Dean of the Faculty of Medicine here at Memorial, to come up and talk about the impact of the faculty, achievements and opportunities.
Good afternoon, and thanks very much, Dr. Locke and your team, for inviting me here. I have a bit of a cold, so if I start sputtering, I apologize, but I want Dr. Parfray to know I'm choosing wisely and I'm not on antibiotics. So there we go. So I've been asked to talk about the role of the Faculty of Medicine, and it was really an opportunity for me to reflect on what we're doing in the faculty, but what can we be doing a lot different. And we do influence health outcomes, and we do look at healthcare costs, but we have lots of things that we have to be doing more of. So my conflict of interest is that I'm a leader in the Faculty of Medicine, so I'm somewhat biased because I think we have an important role to play in the province. So what I hope you all are able to describe when you leave here is a little bit about the origins of our faculty and what it's like now, because we don't just educate physicians, we actually educate healthcare researchers. Talk a little bit about the key achievements and impacts and how we've influenced the health of the people of the communities of Newfoundland and Labrador and beyond, and talk about our mission, vision, and goals in the next 5 years and the opportunities. So some of you may be aware, but Lord Brain did a commission in the 60s and advocated for a new teaching hospital of 400 beds and a medical school of 40 students. And then Joey Smallwood decided to implement that. So in 1967, our faculty was established. And the man on my left is Dr. Ian Rusted, who was the first dean of the faculty, and he started his work in 67 and took a couple of years to get the curriculum going. And then on the right is that dashing class of 1973 with the first 23 medical school student graduates. So now, what does our faculty look like? Well, we have 80 medical students a year, so we have 320 undergraduate medical students. We have about 300 residents and 360 graduate students per year, and that has increased significantly over the years. We have about 350 staff and about close to 1,400 faculty members with 278 full-time. But what you see there is we have over 1,000 part-time faculty, most of whom do it on a volunteer basis, that they're committed to educating our students. So in 2014, our school actually won a Social Accountability Award internationally. But I think although we're doing great, I think, in social accountability, we got a huge way to go. So what does socially accountable medical schools mean? It means the obligation to direct our education, research, and service activities towards addressing the priority health concerns of communities, region, and our nation to serve our mandate. And the priority health needs are to be identified jointly by governments, healthcare organizations, health professionals, and the public. And I think there's been lots of discussion about how the NLMA and the government and NELCHI and other organizations work together to set research priorities. The World Health Organization says to be socially accountable, we have to look at 4 key areas: relevance, quality, cost effectiveness, and equity. And I think that where we need to go more is looking at the cost effectiveness of the school and how it impacts healthcare costs. So schools who are socially accountable must be meeting the workforce needs, understanding the health issues, and our products, that is our graduate service models or research findings, are in the best interest of the public. So how do we do that? So we start very early. So one of the things that you heard from Dr. Dwyer is that 40% of our physicians in this province are international medical graduates. So how do we get people from our province to be practicing here? So we start at the high school level, and we have a program called MedQuest. So our students go out and approach high school students and tell them about not just medicine, but other healthcare professions. We also do that with Indigenous youth, and we have a program called the Healers of Tomorrow's Gathering. And that's important not only for those Indigenous youth to find out about different health professions, because we have pharmacy students, social work, etc., but also our students learn about Indigenous health through those camps. So currently we have 80 medical students, as I said. 60 of them come from Newfoundland and Labrador, and we have 3 diversity priorities. The first one is Indigenous students. So we have 3 dedicated spots per year. Now, there may be more Indigenous people, students, because they may not self-declare. We also have a priority of students from rural communities and students from lower socioeconomic families. So once they get into medical school, how do we actually get them to think about careers out in rural Newfoundland where the needs are high? So we expose them right at orientation to rural communities, and then they do rural placements. And that's all over Newfoundland and Labrador. We also embed them in clinics that are not necessarily in the university and hospital settings, because again, we've heard we want to move more to community care, so we need to train our future physicians about being in the community. So we have a clinic, for example, called Gateway, where our medical students go and meet with new Canadians and learn about them and also healthcare and the social determinants of health. We also have the curriculum, which not only is teaching traditional basic and clinical sciences, but also population and health and social sciences. So as Dr. Parfray said, we really need to be addressing social determinants of health. So if our graduates understand them, they can advocate for those services for our individuals. At the postgraduate training level, so that's after you graduate from medical school, we've actually done some studies here in the faculty indicating that if you do postgraduate rural training, you actually are more likely to practice in rural areas, even if you were from an urban center. So the Faculty of Medicine has been implementing family medicine residency programs since 1973. And in 1992, we developed a very innovative program in Happy Valley Goose Bay. And in the late 1980s, in some of the Hansard reports from the government, it indicated that there was a devastating, chronic, desperate situation for physicians in Happy Valley Goose Bay. And so when this program got instituted, there actually is a really strong cohort of people working there now. We also started a similar program in Nunavam in 2011. And in 2012, we have residents going out to the Corner Brook Region, Central Regional Health Authority as well. So when we choose the residents in family medicine to go into these programs, we're actually really identifying students who are interested in rural medicine. And so they have to show an interest in family medicine because most physicians in rural areas are primary care practitioners. They may have evidence where they've done rural family medicine training opportunities. So this is just a study done by Maria Matthews in our Division of Community Health and Humanities. So in 2004, approximately 40% of the physicians in Newfoundland were Memorial graduates, and 8% were working in rural areas. What you see in 2014 is we actually had 55% of the physicians in Newfoundland were Memorial grads, but still about 8% in rural areas. So we'd really like to increase that number in rural Newfoundland. And then at the continuing education program, we've been working with the Department of Health, the college, Linda Inkpen's college, the NLMA, the health authorities, to actually develop some programs to ensure that physicians who are out there and they might have a different scope of practice. So maybe they've been practicing in an area where there weren't very many elderly patients, but now they know their population is aging, they're going to get some retraining so that we're trying to be keeping our physicians in the province longer and practicing to the needs of the province. So switching gears from education and producing physicians and assisting physicians, there's our research contributions. So some of you may be aware of the condition that's quite prevalent here in Newfoundland, the arrhythmogenic right ventricular cardiomyopathy. So two of our researchers, Dr. Terry Lynn Young, a geneticist, and Dr. Kathy Hodgkinson, a clinical epidemiologist, discovered an unknown disease gene and a causative mutation. So before we had this ability to test individuals to see if they had the mutation, about 50% of males and 5% of females would actually die by the age of 40, and 80% by 50 in men and 20% of women by 50. So now, if they get the blood test, they can actually offer them an implantable defibrillator, which actually allows them to live much longer. And so that they're going to be working longer, contributing to the economy. Another researcher is Dr. Thomas Michalak, and he's been studying hepatitis for over 30 years. And he has one of 2 woodchuck colonies in the world. Woodchucks are a good model for hepatitis, apparently. And he has found that people who have hepatitis B, who may not necessarily have symptoms, actually can develop liver cancer. And so with that, they can try and target treatments. Again, improving health outcomes potentially. Dr. Craig Moore is studying multiple sclerosis. You're probably aware that Canada has the highest rates of MS in the world, and Atlantic Canada has the highest rates in Canada. And although we don't have the accurate stats in Newfoundland, about 1 in 340 individuals have MS. So what Craig Moore is doing with his team is discovering a method of cell-to-cell communication that may lead to new drug therapies for MS and other brain diseases. Another one of our Canada research chairs is Dr. Michelle Plowman, who happens to be a physiotherapist. She's studying rehabilitation in stroke and MS, and we've heard we have high prevalence of strokes. And so she's looking at new ways to promote repair and restoration of function in stroke and MS with new rehabilitation techniques to reduce disability and improve quality of life. So if you have better quality of life, you're in the workforce longer, it also would reduce healthcare costs. Dr. Diana D. Carvalho, she's actually a chiropractor in our faculty, cross-appointed to human kinetics and recreation, and she's looking at low back pain. So in a recent study in Newfoundland, about 21% of people indicate they've had low back pain in the last 12 months. So again, she's looking at biomechanical and neuromuscular responses to prolong sitting, like we're doing today. So what are the things that we can do to prevent low back pain? Our next Canada Research Chair is Dr. Ben Zendel, and he's looking at aging and auditory neuroscience. And soon we will have the oldest population in the world, so it's important to address whether or not we're having these healthy elderly patients. So he's actually recruited elderly individuals and found that playing a 3D video game for 6 months improved the short-term memory, but more importantly, it actually changed the region of the brain. So if we can do more activities and learn about what we can do to keep our elderly healthy, the better for our province. Dr. Tom Belbin, he's a scientist in oncology research, and he's looking at modeling to develop what they call molecular signatures that can distinguish clinically aggressive behavior in cancers from non-aggressive, and again, focusing treatment. Dr. Proton Raman, who's our Associate Dean of Clinical Research, he's very active in translational genetics research and has identified several novel genes in spondyloarthritis, as well as new genetic markers for disease progression and pharmacogenetics in psoriatic arthritis. And he has established a relationship with Janssen Pharmaceutical and looking at research related to patients with psoriatic arthritis. And then Dr. Chris Aubrey-Basler at the back, who spoke earlier today. He is the director of our primary care health research unit, and they're doing a number of studies, and I can't go into all of them, but one of them is the BETTER program, which is building on existing tools to improve chronic disease prevention and screening in primary care. So they've trained about 20 primary healthcare providers, and they are using different tools. So at the first visit, what questions should you be asking? And they're trying to change lifestyle factors so that patients will be living healthier lives, and then also screening for chronic disease and intervening appropriately. And preliminary studies have actually shown that this has been effective. Stephen Bornstein, also here in the audience, he runs the Newfoundland and Labrador Center for Applied Health Research, and they have a program called CRISP, in which people in the province will provide research questions, and then they're in essence voted on by our healthcare leaders in the province, and then they do a synthesis of systematic reviews, and then they have a local and national and international expert who actually works with our local academics and health system partners to answer questions. So an example would be fall prevention in long-term homes or youth in residential cares. And then what they do is once they look at that evidence, they contextualize it to Newfoundland and Labrador, because what works in Toronto isn't necessarily going to work in the Burin Peninsula. They also have a number of research exchange groups, and one of them is on cost and value in healthcare. And some of the goals are informing health policy to reduce costs and increase value, examining best practices around the world and then having them implemented here, identify programs that have a good use of healthcare dollars, and ensure that any new healthcare initiative includes evaluative components. And yesterday I had a tour actually with Mike Doyle, who's also in the audience from Eastern Health, of their research unit and looking at how they're evaluating their programs, which is so important. Another program that's very unique that we have is 6 for 6, and we have 6 physicians from rural and underserviced areas who come to St. John's 6 times a year to learn about research. And what the hope is that they would have a research question from their community, pertinent to their community. They would go back and study that, and that way they can develop a research program in their community. And this has allowed many benefits, including addressing health priority needs for their region, establishing a network of rural researchers, and then disseminating information. Now, the other issue is economic impact of medical schools, and Mr. Gillingham talked about the economic impacts of pharmacists. So there actually was a study done in 2013 of the economic impacts of Canadian medical schools and affiliated teaching hospitals. And they measured both the direct economic impact as a result of education, research, and clinical services, but also government revenues and the direct and indirect employment generated in Canada. So their report showed, so that you're aware, there are 17 medical schools in the country. The economic contribution was estimated to be $66.1 billion, and 1 in 60 jobs in the country was actually attributable to academic medicine, and more than $13.9 billion in government revenue is generated as a result of academic medicine. And then there was a separate one for each school. So this is the results for Memorial and Eastern Health, so that they found that the direct expenditure for goods and services by the Faculty of Medicine and the primary teaching hospital, employees, learners, and visitors, was $843 million, and indirect spending was $927 million. So we are contributing to the economy, recognizing there is a cost to having a medical school in your province. So moving forward, we've just launched our new strategic plan, Destination Excellence, and our mission is to, working in the spirit of partnership and respect, the Faculty of Medicine is committed to delivering integrated excellence in education, research, and evidence-informed care, meeting the unique health needs of our rural, remote, and urban communities, and advocating for health, equity, Indigenous health, and healthy populations. So we have a big mandate, but we're committed to moving that forward. And our vision, which I'm trying to impart on everyone so that they can recite it, is that through excellence we will integrate education, research, and social accountability to advance the health of the people and communities we serve. So in order to achieve our mission and vision, we need to have outcomes, and we call these outcomes improving lives. So the 3 main outcomes, one is thriving learners and graduates, so that our graduates are actually prepared to respond to population needs and to be tomorrow's scientific and clinical leaders. So they need to understand about the healthcare system, the costs, social determinants of health, etc. The second outcome is impactful research, and the third one is healthier communities. So the second pillar is our strategies of excellence. So in order to actually achieve those outcomes, what processes and practices what must we excel at? So we call this excellence in all we do. And the educational excellence is we must excel at providing learners with active, engaged, empowering, and authentic community-based experiences that include longitudinal learning activities. Our research excellence, we want to build robust academic and external partnerships and networks, and that's with patients, with community agencies, with other health professions. We want to effectively disseminate our research outcomes to the scientific and clinical communities and the public. And I must say, I think we have to up our game a lot in communicating what we're doing to the public and also getting the public voice. So just so that you're aware, when we did our strategic plan, which took over a year, we actually had focus groups with patients, with community stakeholders. We had individual interviews. So we're really trying to engage our community in the school and vice versa. The third area we have to excel at is social accountability. So we have to actively listen to and collaborate with the populations we serve and our health and research partners. And we need to develop partnerships that strengthen community capacity in underserved populations. And I think that's a very important role that we play. We do have our students in community services, but I think we can expand on that. So looking to the future, I've had some discussion with Sister Elizabeth about this. We have slightly, perhaps, different views, but she's a bit more experienced than I am, to establish a community advisory board and other pertinent reference groups. And some of the literature indicates that that's really helpful because people in the community can help us evolve our curricula. So even though we have accreditation standards with certain things that students have to learn, we also have to make our learning pertinent. So recently, for example, with prescription monitoring, the introduction of electronic health records, we have to make sure that our students are actually learning about that. So we have to make it pertinent to the province. We also can work with the community to establish a list of our research priorities. And we can also develop and enhance electives for medical students and residents in public health departments, and also have practicum experiences for our graduate students in the health department. So they might be able to work with government officials around looking at policy and changing policy that will help health. The other really important thing that on reflecting on what we do, what we really have to up our game in is establishing outcome metrics. So as a school, what are we doing and how are we actually impacting the health? We haven't had as many health indicators. I think with the Choosing Wisely campaign, there's been lots of more health indicators. But I think as a school, we need to have health indicators of the communities we serve. We also have to identify, for example, the number of students who are involved in community projects or who are out there in rural areas. So one of the things that we do well is we have resident training in family medicine out in the rural areas, but we don't have as many specialists going out into the rural areas to learn. And so in fact, last night I was at a meeting with some of the VPs of medical services in the province and our program directors about how can we get more psychiatry residents or surgery residents out in the province. But the other flip side of that is we actually need to know what the workforce demands and needs are in the province because we actually don't have a really fulsome account of that. The other thing we need to do is follow our graduates, both our medical graduates, but also our health science researchers, to see how they're actually serving their community after graduation and are they staying in the province. The other thing is this introduction of longitudinal integrated clerkships. So what that means is in the medical school, they have a 4-year curriculum. And in the 3rd year, they spend the majority of their time actually in clinical settings. Many other programs in the country have longitudinal integrated clerkships, which means that up to 6 students would go to a community, say Stephenville or Botwood, and they'd actually learn there. So they would have a primary supervisor, a family physician, and they'd follow the patients over time and then go to the specialists with the patients. So they would get a sense of living in a small community as a physician, but also what are the social determinants of health, how they can advocate for their patients, and understand systems-based practice. And these type of learning opportunities have actually been shown in studies to be as effective as our traditional type of clinical training. The other thing is working with the Department of Health and Community Services and the RHAs to better determine the workforce needs, which I mentioned, and look at more fulsome strategies and initiatives to recruit locally trained specialists. Now, last week at the school, it was a very exciting week for our graduating medical schools because they got matched to their residency programs. And in fact, 65% of our students are staying in Newfoundland for their residency program, which is fantastic. I was at a meeting with NLMA a couple weeks ago. I said 60% would be good. So I'm feeling really encouraged. They go at 65%. I think the other thing is the Faculty of Medicine to host a social accountability event or workshop and invite key stakeholders and invite the public. And I think that all voices are important, regardless of your health profession, whether you're a patient, a family member, that sort of thing. I think we need to work more together. And what was very evident to me as I was thinking about the school is that we really actually need more studies looking at the economic impact of what we're doing as a school, as well as the discoveries and innovations that we're making. Right now, we don't have, we have one part-time health economist, but we probably need more and probably need to be liaising more with Dr. Locke and Dr. Gambin about looking at health economics. So although I had a lot of slides, I'm actually below time, which is good in the afternoon. So I'm open to any questions. Thanks for listening.
You caught me off guard there, so thank you for that. That was great. Open up the floor for questions. Back here, Mike, Claire.
Hello. I have a two-part question. One is, how much wood does a woodchuck facility need to operate?
Dr. Mikulak's not here, so I can't. They're little Labrador woodchucks, by the way.
My serious question is, some medical schools in Canada are more healthcare schools. They incorporate medicine, pharmacy, nursing, etc. And where we are talking here today about combining or collaborating more closely between disciplines, how much of that is happening within the structure that we have of different faculties and schools, and what more could be done?
Okay, so we have a couple of the deans here, Donna Hardy-Cox from social work and Alice Godine, where's Alice? Right here, from nursing. So Alice has actually pulled us together. On every 2 months we're meeting. The other dean is Heather Kanaran from Human Kinetics and Recreation, and pharmacy, Lisa Bishop. Oh, Lisa's here as well. So we meet every couple of months, and that's just started this year. We also have a Center for Collaborative Health Professions Education, CCHPE, and there's a governing council, and all of the healthcare schools are represented, as well as education, as well as the Student Wellness Center. Within the Faculty of Medicine, we also have a physiotherapist, and in addition to the one I referred to, an occupational therapist. So I think we're kind of looking at ways that we can work more effectively. I had a meeting recently with the RHAs of the CEOs. My colleagues don't even know this yet, but I put on the table, could we meet with them, with the health sciences dean, so we could work more effectively together? And they were very open to that, and so we're going to have to develop that retreat. So there's lots more we can do. With our interprofessional initiative, which, you know, I come from Western in London, Ontario, and I think we do a fabulous job at the undergraduate, pre-clinical for interprofessional education, but we really need to expand it in the clinical settings and out in the RHAs and community services where students of different professions are working more together. Yeah.
Another question from the floor?
Everybody wants to.
Okay, just over here in the middle.
Hi there. Is this on? Weird. Oh, there. Okay. Hi there. So we have an aging population, and I'm particularly interested in palliative care, and I know there's a lot of research to show that having a palliative approach to care and education about palliative care in medical schools can improve health outcomes, improve quality of life, and end up reducing healthcare costs, particularly at end of life. So what is the university doing right now with respect to kind of educating undergraduates in palliative care? Is it how many hours are contributed to that? And is there a plan to expand that over the coming years as the population ages?
So palliative care is embedded in the curriculum. The number of hours, I couldn't speak to that in the medical school. I don't know if my colleagues in the other faculties want to speak about how much palliative care they have in their faculties, but it's integral, and it's not only just related to the aging population. It's actually, you know, anybody with a chronic illness, and traditionally it's been associated with cancer, but it's any chronic illness. And as Dr. Parfrey said, we can do better job at educating students on breaking bad news. We also, in family medicine, have a track, I believe. Is Chris still here? Chris, we have a track in palliative care, do we? We have one in care of the elderly.
There's care of the elderly, there's an underserved population. There's no specific third-year program in palliative care, but there are a number of palliative care docs in all.
Hi. So we don't have we don't yet have a third-year program in palliative care, but all the residents do rotate through and do some palliative care during their 2-year family medicine residency.
Thanks, Chris. Yeah. So Dr. Malay, who's our Associate Dean of Community Health and Humanities, was just reminding me that we do topics of palliative care with the ethics group, and we have a strong ethics group, and they've just established a center of bioethics here. The other thing, though, about the elderly, so it's not just palliative care, it's actually the elderly. So you can become a physician working with the elderly in different routes. And so there's the Royal College route. And we actually, in this province, only had one Royal College specialist in geriatric medicine. But we have a number of family physicians. I don't know if Dr. Butler's still here. Dr. Butler, do you want to speak to that?
We have 3 students enrolled for this year coming. One student will be starting next week, and we have 2 more starting in July. We've already graduated 2 students. We have 5 now in the pipes, and there's a lot of interest developing in geriatrics in the residency program. So I think we're here to stay. I've been sort of beating this drum for my life, but it's really we're at a really exciting time in university, and we're looking at hopefully expanding the training program over the next few years. With accreditation coming up, that'll probably be on our agenda.
Yeah. And actually, you probably know this woman, but there was a career night for the medical students for specialties, and I bumped into one of the family medicine residents, and she was very excited to tell me that she just finished her emergency medicine rotation and realized that geriatric medicine was the place for her to be. So I thought that was terrific. Yeah.
Dr. Steele, David Vardy. I wanted to ask you a question. Listening today to the various presentations, it seems to me we have a number of very complex issues we're dealing with in the delivery of health care, perhaps an inappropriate balance between hospitals and institutions and the physicians when you look at some of the numbers. And also we hear a little bit about the institutional models for our hospitals and there's some evolution required there in terms of some kind of a different model. And so I'm curious as to how you see your faculty in terms of training managers for the health institutions in our province. I'd like to hear what you have to say about your training, and then whether there's any work between your faculty and the Faculty of Business with regard to training the people that run our healthcare system. Because it seems to me that one of the things we do in Newfoundland is we emulate other jurisdictions. We follow the models that the rest of Canada creates with a 20-year lag, and we don't really adjust for Newfoundland conditions. And what I hear from your predecessor and from you is that this medical faculty, this is tuned to Newfoundland and Labrador conditions. And I think that it's really important for us to develop people with skills to address the peculiar challenges of Newfoundland and Labrador.
Yeah, I agree with you completely. Just so that I'm going to speak a bit from my own discipline. So I'm a child and adolescent psychiatrist. So I've been used to, in my career, working with other professionals, probably more other professionals than physicians, and also working in communities and building community capacity. And I think one of the issues for us from institutions to community is building capacity in the community so they have the knowledge of how to move things. So I know in mental health, unfortunately, there's long wait lists here. And part of it is people are a bit anxious about how to manage it. So that's a bit of my own issue. The other point about business, we do have a program which actually the regional health authorities, NLMA, and the Gardner Institute and the Faculty of Medicine run on physician leadership. And so in our strategic planning process, we actually want to expand on that because it's kind of it's a really good program. People, we've written about it, they learn skills, but we need to develop almost a tiered approach to leadership, and we have sort of emerging leaders, and then we need leadership for senior leaders. Now, just so that you're aware, from the manager versus leader, we're moving to competency-based education, and one of the competencies that we have is leader. So we used to call it manager. It's a CanMeds, that's what it's called. It used to be called manager, but we realized physicians, whether you have a formalized title of leadership or not, have to be leaders and to know how to manage resources, align the resources, work with teams, those sorts of things. So it is a big initiative for us. And I think we'd like to expand our relationship with the business school. So I hope I've answered your question.
I'd just like to elaborate and move to another level. When we recruit for university presidents, we're always looking for somebody from academia. We don't reach into the pool of managers. We ask for people with PhDs. Now, transferring this into the field of faculties of medicine, and the whole business of running hospitals. There was a time when physicians ran hospitals. Now we have administrators who are not necessarily medical trained people. What's the current thinking on the kind of people we need to run our healthcare institutions? I wonder if you could comment on that.
So I think that we need leaders who have the competencies. And I think, your comment about for university presidents, we hire PhDs. I understand that in an academic institution, but I actually think the leaders have to have the competencies. They need to be able to collaborate. They need to be able to be politically astute. They need to be able to communicate effectively. And sometimes I think a researcher, I'm just going to choose that one, especially in my experience in medicine, isn't necessarily got the leadership skills. They may very well have them, but I think you really should be hiring for competencies. Now, the whole issue about physicians and physicians running hospitals, you may be aware there's a national organization called the Canadian Society of Physician Leaders, and they've recently done a survey about physician leaders, and most physician leaders fall into the position because we view leadership as the evil, the dark side, but there's really a push nationally to have physician voices more, and I think they would advocate that we have more physicians involved in leadership in hospitals.
Thank you.
Yeah.
Okay, we've got time for at least another one, but probably two. One here in the front or in the middle.
Hi. I believe you said there were 60 graduates, 60 people admitted to the program each year, or what was it?
60 from Newfoundland and Labrador, so there's 80. The other 10, we have designated spots from New Brunswick. They pay
Right.
for our spots.
Right.
4 from Prince Edward Island. Right now, 1 from Yukon, and the rest come from the rest of Canada.
Okay. So having lived all my life in Newfoundland, I know that over the last 30, 40 years, there's always been an issue in terms of recruiting healthcare workers for certain areas of the province, and doctors and so on being one of those. I know that in some areas of healthcare, such like physiotherapists or different practices like that, I think that the province enters into some kind of an arrangement to help certain students go away and get that training in return for service in the province. I just wondered, with respect to training physicians, do we have anything like that, alive in our current faculty of medicine?
Not currently. There were in the past, and Maria Matthews actually did a study of the return of service agreements, and I know Dr. Parfrey mentioned that. There's mixed reviews in the literature about how well return of service agreements work, because sometimes what happens is people buy themselves out of those agreements, and they don't necessarily, but the people who continue actually will continue in those regions. Now, the interesting thing is the College of Family Physicians of Canada had a conference in Happy Valley Goose Bay in the fall, and the president, Francine Lemire, who's actually from Corner Brook in Newfoundland, mentioned that what they're looking at recruitment and retention rates for family physicians in rural areas is 3 years. But we would like to see it longer. But that's what the national standard is. They're trying to get people in the communities for at least 3 years.
Okay, one last question over here in the back. Can we just get the microphone to you really quick? They're on the way.
No, I just wanted to add that the Department of Health and Community Services still has bursaries and signing bonus programs for physicians in hard to recruit rural and remote areas primarily. So it's
Thanks, Heather.
Any more questions from the floor? Okay, so thank you, Dr. Steele,
Thanks very much.
very much.
Thank you.